PTSD on their families. But the vote will come back to whether you think it's likely that this treatment will have a substantial impact on that. Stephanie, please go ahead.
Thank you. Point of clarification here. Should we be thinking about impact like short-term treatment during the actual MDMA and psychotherapy treatment, or should we be thinking like long-term impact, like a year after this, for example?
That's a question I honestly probably never thought about enough, but I think that the general thrust of the question is to try to capture potential benefits in the longer term with effective treatment. So I mean, maybe I'm imagining this, but it could be that the family is going to have to go through a lot of short-term hassle to take patients to appointments or to deal with whatever, but longer term, they might benefit if the patient or the person gets better. If that's what you were thinking, I would emphasize the longer term potential benefits.
Excellent.
Yeah.
That's exactly what I was thinking.
Okay.
So thank you.
Okay. But again, just to, I guess, maybe overemphasize, but you have to link that to your earlier judgment of whether you think the treatment is likely to have an effect on the individual that would, if you will, spill over to help patients and families. But I want to hear from our patient experts on this, and clinical experts too, if you'd like to weigh in. But we've heard very eloquent, and we know the pain, the difficulties, the unmet need. How does that affect families and caregivers? Diana?
I made 2 comments about this in the report itself with regards to the caregiver. There's 2 perspectives I was thinking about. One is, of course, it's an exhausting thing to be a caregiver. I've seen my own family, of course, live through this. And it does often get to a point where you just are looking for something, anything to be the solution. And if something is framed as a panacea of sorts, or as more effective than it is, or whatever else, you do get into situations where it's almost like, okay, well, if this is a thing that's finally going to solve it, I'll finally be free. Let me just push them towards this direction, regardless of if this is actually the best option for the patient. But the other side of this that I've seen a lot as well, because I work primarily with BIPOC young adults, is that there is a huge culturally based stigma around drugs in general, pharmaceuticals in general. And so that there's already so much difficulty in having family members understand when you have to take medication as it is. That conversation, when it escalates to the level of something relatively novel to their discussions like MDMA, it can cause a lot of panic and fear. And I've heard this a lot with the parents who I talk to as well, who have been dealing with this.
That's interesting. Thank you. Naomi, anything you'd like to add?
Yes, thank you so much. So PTSD really can take parents out of their relationship with their children. It can be paralyzing, which is really particularly painful in the context of coming home and reuniting with loved ones. And so for veteran families, you know, really PTSD touches everyone. So that's what I did.
Thank you. Okay, why don't we go ahead and come back to the voting question, which again is framed in a way that I think a pure survey expert would frown on, because we're asking you to think of 2 things when answering one question. The first is whether it's likely to produce an effect that will be helpful for the individual, and whether that effect would have substantial benefits, if you will, for caregivers. So with those 2 factors in mind, why don't we go ahead and vote? You either strongly disagree up to strongly agree with the treatment is likely to produce substantial improvement in caregivers' quality of life and or their ability to pursue their own education, work, and family life. 15 answers, 9 neutral, 5 disagree, and 1 strongly disagree. Okay, I think we're into the home stretch here. We have 1 more question. And again, these questions are not tailored to the specific drug. We do these questions for every single, treatment or intervention that we look at. So this one is about the potential for a new intervention to offer a substantial opportunity to improve access to effective treatment by means of its mechanism of action or its method of delivery. So again, there's perhaps too much going on in this question. But the idea is to capture whether there are sometimes new interventions, and I can give just a simple example. If treatments are all limited to intravenous treatments that have to be given once a week for the rest of the patient's life, and instead they can get one shot at home and they're done, that kind of change, even if it's the same clinical effects, we would all think has greater value because of the ability to improve access and adherence and all the other things. So we're asking about whether this treatment offers a substantial improvement, et cetera. Austin and then Stephanie.
Sorry, at the very last second with the last question, I realized the way I was interpreting it was I was adding in front of it, is the evidence adequate to support that, blah, 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 blah. So that's how I answered that. That may or may not be relevant to this question as well. But maybe I need to ask for questions like 5 and 6. Is it an adequate evidence type question, or is it not?
It's asking you to do two things. It is asking you to say, what is my understanding of the likelihood that this treatment has this effect?
Yeah.
So if you have low confidence in that judgment, then you would have low confidence that it would have this secondary effect, if you will. Now here it's a little bit, it's again, this is tricky because we're saying, does this by its mechanism of action and or its mechanism of delivery, does it offer a special opportunity to improve access to an effective treatment? So we're still asking you to, in a sense, think about two things. But it's fair to talk about, one or the other. You could say, different things about its mechanism of action or its delivery, and then different things about your level of confidence that that actually works. So if I haven't confused you all completely, I'd be surprised, but let's see what the questions or comments are. Stephanie?
So I've been excited about this question all day because psychopharmacology, like this is my jam. And so the way I'm approaching this is I'm kind of teasing out MDMA here for this one, because I am really excited about a completely new mechanism of action, right? Like this medication works very differently than any other medication we have in general, really, and then more specifically related to treatment of PTSD. So I do think that this is a novel mechanism of action. And then I think also it's different than other pharmacotherapy for PTSD in that it offers a protocol that's not forever. Unlike SSRIs, which are not first line, right? Non-pharm is first line, but are our first line pharm for PTSD, which would be, in many, many people, a tablet for the rest of their lives. So I think both from like mechanistic perspective, the way it works and flipping that CERT transporter, which is just like fascinating. And I would love to talk about anyone all day about that offline. And then also the way it's protocolized, different than other pharmacotherapy we have, really does offer a novel mechanism.
Okay, thank you. Steve?
My question follows up to Dr. Nichols' topic, and wondering if there are maybe a subgroup of patients for which the access barrier is more about the patient not wanting to try or retry CBT, or, maybe now that there's a medication, they might consider CBT with medication or therapy with medication. So, at first, my first sense was this was a disagree, but now I'm wondering if, maybe there are people who would be willing to try a drug rather than just psychotherapy itself. Any thoughts about that?
I'd like to hear from the clinical experts. In your experience, how would you answer Steve's question?
So I don't think there's like great data on this about, there's not like a nationally representative survey of people's with PTSD's preferences for treatment. I will say anecdotally, I'm doing a trial on MDMA and prolonged exposure, and I do think there's a subset of people who are willing to do MDMA plus CBT that have not sought out CBT on its own. But that being said, there still is a really good group of people that just cannot access trauma-focused therapy. So I do want to be clear about that. But I think there definitely could be people who are more open to this treatment option. And again, giving patients with PTSD choice, I think, is really important. And this countering avoidance, and MDMA potentially being able to do that and make people more open to engaging in trauma-focused therapy and, you know, feel more confidence in their ability to potentially tolerate it could be a good path forward. But again, there's not great, like, clear systematic data on it.
How is this being viewed in your country? Is it being viewed as a way to increase access, to provide special new ways to bring people into treatment, or is it too early to be viewed that way there?
It's a good question. I think it would depend on who you ask. So I think proponents for this treatment would say that this is a way to give patients access to a new treatment or a better treatment. But if you ask conservatives or critics or whatever you like to call it, like me, I'm more skeptical. We have to keep in mind that this treatment consists of 84 hours of therapist time compared to 18 to 16 hours of therapist time for already existent good evidence-based treatments. So I'm a bit skeptical whether this would actually improve access to effective treatments for many patients.
Thank you.
Yeah,
Tara.
and
Oh,
sorry,
sorry.
Jim, I think that's
Go
an
ahead.
important point from Yar, and I think it also reminds me of the question earlier, like the reminder that like this isn't the only model of MDMA therapy. This one is quite therapist time intensive, you know, 84 hours of therapist time and 3 dosings, and that like those things aren't set in stone as requirements for MDMA therapy. Like the protocol I'm testing right now is a one-time dosing in the midst of 10 sessions of prolonged exposure therapy, mostly with one therapist. So just kind of a reminder that like there are different models that are being researched and can be researched in the future.
Thank you. That's really helpful. Tara.
Yeah, I guess a lot of my comments one of my comments relates to comments that people just had, in that I just want to be clear again, this came up before, that we're not talking about MDMA as like a new treatment that's exciting and has potential as a new mechanism of action. Like we're talking about MDMA as it was implemented and studied in this study, right? So I just want to confirm that, because I think that changes my thought process with this, and want to just like make sure like that's exactly what we're talking about here.
Yes, it is. It is.
Okay, thank you.
And as Jessica said, and we'll get into the policy roundtable too. I'm glad you mentioned it now, though. Again, there are MDMA. It's not set in stone. I think that was your words, were your words. And so, but what we have in front of us today is a package in which it's linked to that psychotherapy model. And so that's the question on the table. Let's go ahead and take the vote on that last voting question. Strongly disagree to strongly agree. This treatment offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or its method of delivery. Okay. We have 7 neutral, 5 disagree, and 3 agree. Almost a bell curve, but we will leave it at that. Great. Okay, I think this is excellent, and we're almost exactly on time, which I appreciate, because we have a lot of interesting and challenging issues to come back to in the policy roundtable, which we will start at the top of the hour at 2 o'clock Eastern. So CEPAC members and policy roundtable members, please come back a minute or two before that, and we'll see you at 2 o'clock Eastern.